Professor Genovese, how has the treatment of rheumatoid arthritis evolved over the last decades?
We've seen significant innovations and advancements in the treatment of rheumatoid arthritis over the last decade. First, we've seen the advent, the development of new or novel mechanisms of action. But importantly, we've also seen combinations of traditional medications being used together. And of course, the advent of treat-to-target strategies designed to help us more aggressively treat patients to an appropriate target to deliver greater levels of improvement and function.
The disease remission is the key goal in the treatment of RA, yet a significant proportion of patients do not achieve that. What is the reasons for this?
Well, we still struggle to achieve the level of response we would like. On average, we achieve remission between 10 and at best 40% of our patients, depending on the cohort you look at and how early they are in their disease status. In general, we need to come up with more sophisticated strategies to result in better impacts on our patients. That would include the development of biomarkers, novel mechanisms of action, and hopefully as we move forward, additional combination approaches that might take advantage of our novel therapies now, start putting them together with additional novel therapies.
Talking about the novel therapies, what are rational combinations and where should clinical trials take us in the future?
I think we have to start thinking about adding new medications onto our standard of care. And right now, standard of care is a biologic plus methotrexate. If novel therapy can be added onto that regimen, we might achieve higher levels of success. Obviously, we have to do that in a careful, cautious way because we don't want to see large safety problems develop. But we'd like to achieve a higher level of success when we think about low disease or remission.
You are about to present your study on the long-term safety of filgotinib. What were the study's main findings and what do the results imply for new therapeutic options for RA patients?
We've been fortunate that we have been able to follow patients that completed the Darwin 1 and the Darwin 2 studies. Those were two large clinical trials that assessed filgotinib either with or without methotrexate in patients who had active rheumatoid arthritis. In the extension study now, we have over 1,700 patient years of exposure. We're able to assess long-term rates of complications, such as adverse events, side effects such as infection, and other side effects, including laboratory abnormalities. The nice thing about the data we've seen so far is that we've seen no increase in the overall rates of events that have been taking place, and no unique, unusual side effects develop. We've also been able to assess patients for long-term success as far as durability of response. And we're seeing a consistent response with continued exposure to medication.
Regarding kinase pathways, where might future research take us here?
We have so many potential options. The key is to understand which ones are most likely to result in clinical benefits in rheumatoid arthritis versus some of our other diseases. And as we address unmet needs, we may be able to pivot to other diseases in the future.
Professor Genovese, thank you very much for your time.
Thank you.